delivering thoracic radiation is a complex undertaking, and I want to take a moment and discuss that. So for a standard radiation treatment of 60 gray of radiation, given in 2 gray fractions over about a 6-week period, the radiation oncologist needs to ensure that you're delivering an adequate radiation delivery to the tumor, but at the same time you're minimizing radiation to normal structures like the lungs, spinal cord, heart, and esophagus. So let's take a look at some of these constraints that the physician faces. So ideally, 100% of that radiation dose should be given to at least 95% of the tumor volume, but no part of the tumor volume should receive more than 110% of that dose. Yet no part of the tumor volume should receive less than 90% of the dose. And then you need to worry about the radiation to the normal tissue. Perhaps most importantly, the total lung volume that receives a dose of 20 gray, so 1/3 of what you're trying to get to the tumor, should be less than 35%. We call that the V20, and that allows us to prevent radiation pneumonitis or fibrosis. The average lung dose should be less than 20 gray. The spinal cord should be less than 45 gray. The heart V40, or the portion of the heart that receives 40 gray or more, should be less than 50%, and the average dose to the esophagus should be less than 34 gray. Now, fortunately, major advances in imaging technology and radiation beam targeting have greatly improved radiation therapy efficacy and toxicity, and this is why we've been allowed to start thinking about increased doses. So 40 years ago, when planning radiation, a radiation oncologist just had a plain chest X-ray. You've got a large left upper lobe lung cancer. It's not clear on a chest X-ray to what extent the lymph nodes may be involved, and so what the radiation oncologist has done is taken a wax pencil and drawn on that X-ray a treatment plan that includes not only the primary tumor, but potentially involve lymph nodes above the collarbones, in the mediastinum, and on both sides, the area that we call the hilum. Not only is this imprecise in terms of tumor targeting, but look at all of the normal tissues that are included. There's lung, there's heart, there's esophagus, and other soft tissues. Now fast forward to the year 2013. We have CAT scans, PET scans, and MRI. Not only can we clearly delineate where the cancer itself is, but with computer assistance, we can very closely tailor the radiation beams to get high doses to the tumor itself, but relatively little to the spinal cord, esophagus, and normal lung. And it's these advances that have led to the RTOG, Radiation Therapy Oncology Group 0617 trial. And this is the first abstract that I'm going to discuss today. This study was presented by Dr. Jeff Bradley from the RTOG. Originally, this clinical trial had 2 arms. These are all stage 3 non-small cell lung cancer patients who have not been treated previously. And they all get thoracic radiation with concurrent chemotherapy, a regimen of carboplatin and paclitaxel. One arm was standard dose of 60 gray, 5 times per week, Monday through Friday, for 6 weeks. The other arm had the same chemotherapy, but a higher radiation dose than we do normally. This lasted about 7.5 weeks. Subsequently, the study was modified or changed to add a drug called cetuximab, which is an antibody targeting EGFR, or epidermal growth factor receptor. So it becomes a 4-arm study at that point because you're adding this drug to both the low and high dose arms. Now, we don't yet know the results of the cetuximab effect from the recent presentation, so I'm going to focus solely on the question of the effect of the radiation therapy dose. In general, the results were not only surprising, but very disappointing. Not only does it appear that the higher radiation dose was not beneficial, it really also appears that it may be detrimental. So let's look at local failure rates, the chance that the cancer recurs at the site of the original tumor after treatment at some point in the future. The rates are higher in the high-dose arm. After 18 months of follow-up, 34% of patients who got the high-dose 74-gray radiation had local failure, with a lower rate of 25% in the standard radiation group. Similarly, progression-free survival is shorter in the high-dose arm. At 18 months, it's about 26% compared to over 36% in the low-dose arm. Most importantly, overall survival is shorter in the high-dose arm, with a median survival of under 20 months compared to a median survival of almost 29 months with the standard radiation therapy, corresponding to 18-month survival rates of 67% and 54%. All of these analyses were highly statistically significant differences, in this case a p-value of 0.0007. So what can we conclude from this study? Higher dose 74-gray versus 60-gray radiation therapy does not improve outcomes in stage 3 non-small cell lung cancer. Indeed, there was a 56% greater risk of death, a 37% increased risk of local failure. And while I didn't go over the toxicities in depth, the one that really did seem to be different was esophagitis, which was higher in the high-dose group. So what are some possible explanations for these findings? Well, a very large multi-center study, maybe there are some unreported toxicities that occur. We do know that there was increased heart and lung doses of radiation in the high-dose arm, and perhaps because of toxicity, we saw less compliance with chemotherapy and more radiation therapy interruptions in the high-dose arm. Perhaps, as I mentioned before with those radiation-associated changes, maybe in some instances radiation effects were interpreted as disease progression on the CAT scan. Now that might impact your assessment of local failure or perhaps progression-free survival, but that should not impact your assessment of overall survival. So far, after seeing this abstract presented, I think most people would agree that standard dose radiation therapy, a dose around 60 gray, remains the standard treatment for stage 3 non-small cell lung cancer.
Thanks for listening. If you like and learn from our GRACEcast, you can subscribe on iTunes by just searching for the term Cancer Grace, find podcasts in the subject you want, pick a format of audio or video, and then just click subscribe. It's that easy. And for those of you who don't want to miss any of our programs, there's even a feed for all subjects. You can also find us on YouTube at Grace for Cancer Info, and that's the number 4 in one word, Grace for Cancer Info. Finally, if you haven't been there yet, please check out our Grace website at www.cancergrace.org. And don't forget that donate button in the upper right. Our content, which helps tens of thousands of cancer patients around the world every month, is made possible by your support.